We move on to the spatial TAVR session, and here on the TAVR, we request Dr. Sai Satish. His first topic will be TAVI, the desperate men seek desperate measure.
It's always good to see Satish because I always like his smiling face. Thank you. Thank you very much.
Mic chalu hai? Okay. Perfect. So here we go. Good afternoon, everyone. It's always difficult to follow suit after such good lectures, and just for me to take a sample of who I'm speaking to. How many cardiologists are there in the audience? Interventional cardiologists? Oh, good number. Okay. So first of all, I'd like to thank Dr. Rajneesh for giving me the opportunity to spend this time with you. After Dr. Praveen Chandra's crystal clear talk, right, where he went through why aortic valve disease is important to treat, it's going to be quite easy for me to just show you what I do in everyday life. I'm just going to pull up about 4 of my cases back to back. I'm going to go past it quickly. I'd like this to be more of a discussion than a lecture, so feel free to jump in and interrupt me. It's difficult to throw me off track, and we'll see how this goes. So just before I begin, there was a nice article from CMC Velo that said the incidence of aortic valve stenosis is about 1 in 10 once you cross 75 years of age. And they estimate about 3 lakh people will need TAVI, just the TAVI subgroup in India. So it's a huge group. And it's extremely important to treat this group because 9 out of 10 of them will die within 4 years. It's higher than any form of cancer we know. So the first patient I'm going to discuss with you is a small, frail 87-year-old man who had no diabetes or hypertension. He presented with ACS, syncope, developed a gastric bleed, hemoglobin dropped. In hospital, he arrested, CPR, ventilation. You can imagine how it goes when you're 88, 89, you have an arrest, you're on a ventilator, the kidneys shut down. We found a heavily calcified bicuspid aortic valve, extremely narrow valve area, 0.2 with a mean gradient of 100. I've yet to see mean gradients pushing 100, Both surgical and transcatheter turned down, his heart function was deteriorating. I've pulled up this image just to show you. I mean, if you look at the first image there, you can see just the obscene chunk of calcium, right? This valve was all about calcium, rocks and boulders. So I'm not going to get into the technical aspects. In this image, you can see the sheer calcium in the valve. So we get a wire across, we attempt deploying the valve only after ballooning it because we were expecting difficulties. So we do a balloon valvuloplasty, take a valve in, and as you can see, as the valve is opening, it looks like a crushed stent. Even after the balloon, there was no way this valve was going to give. Now the position was good. I could have gone ahead and deployed it and ballooned it, but being a coronary guy, you want to prepare the bed, pull the valve out, took a bigger balloon. So the first balloon was 18, went in with a 22, and then took the valve in again. And even after that, you can just look at the valve, right? And the last time I presented this, one of my colleagues asked me, okay, it looks cosmetically bad, but did you really have to take more balloons in? So I pulled up this. We actually took everything out and did a hemodynamics. And it showed the gradients were pushing 35, so the valve had not even opened properly. So went back with the wire, took a balloon. I love this picture. Just look at the way that left leaflet just breaks open. Can you see that? An absolute chunk, right? So a couple of more aggressive post-dilatations later, we got a gradient of 4 millimeters, no PVL. This is 1 year later. His gradient is 6. He's doing great. This was him at a press conference talking about his second lease of life. The second case I'm going to talk to you about is rheumatic heart disease. See, earlier we had majority of valvular heart disease contributed by rheumatic heart disease. But now, degenerative aortic valve disease is slowly catching up. It's the leader. So 60-year-old man, no diabetes, no hypertension. He had rheumatic heart disease, MVR in 2001, presented with syncope, came to me from Sri Lanka for treatment. Now, the trick in this case is that the aortomitral curtain are all very close to each other. And you have a very proper way of landing your valve without impinging on the mitral leaflet. So we did the case, got the position right, deployed the valve, worked like a charm, and pre-gradient was 86, post-gradient is 11, patient is doing great. So the third patient is post-CABG, AVR at Cleveland, 2 angioplasties in the past, 81-year-old, diabetic, hypertensive. I put 4 stents in his RCA in 2006, another 2 in 2015, kept fainting on me, the gradients were not high, so I didn't know what to do, put a pacemaker in him, and just a couple of months later, he came with the gradient of 60. Of course, he was a surgical turndown. You can see the Carpenter-Edward valve there. We went in with the valve, got a good position. This image is interesting. See, in all these valve-in-valve cases, it's important to see how much alteration of the anatomy. Look at the picture on the right side, right? So the beauty is you don't have to worry about where your pig is. You don't have to worry about it. All you have to do is get the valve in the other valve. You have the frame to go by. So we got the valve in, and I'm just showing this to show you that all my cases up to now have been transfemoral, all closed, all patients have done really well with no side complications. So always important to take the puncture under fluoro and check before you get out. His post-procedure gradient was about 18, and I think that was acceptable. I walked from it, I didn't want to dilate it, didn't want to be a hero that day. It's interesting that we had so much talk about pure AR. So this is one of the pure AR cases I did. 84-year-old man, hypertensive for over 50 years, presented with severe heart failure, multiple hospitalizations, dilated LV, severe degenerative AR, surgical turndown. And sometimes they're just too sick to actually have the CD protocols. So we just do an LAO, we do an RAO, and do a balloon sizing, shoot from the hip, go with the valve. You can see the torrential AR in this patient. And I think the trick to this is to choose the valve. There's absolutely no calcium. And if you ask me, the only thing that helps is the prayer and hope that the valve doesn't pop out. So post-result looks excellent. And of course, the final puncture. So the reason I flew past these cases is to tell you that it's an extremely versatile procedure. It's fairly simple to do, right? It's just a matter of time before we're all going to start doing it. As long as you understand the technology and you plan, right? Contingency after contingency after contingency. You'll have a good day and walk out of the lab smiling. So that's it. Any questions?
Thank you, Dr. Satish. It was real great presentations with all those 4 cases. Any questions from the audience?
Roll-off? TEE? Oh, it's indispensable. So every patient of mine, I've not done many cases. Amit here has done much more than me, and I'm at about my 40 or 42nd case. But the one thing I've learned is always do CAT, do hemodynamic assessment. On table, I have TE for every single patient of mine. I'm blessed with a very good anesthetic team. So I have TE, I do hemodynamics. Like if you look at the first patient, once we put the valve in, once we got everything done, I got the TE in, looked at the gradients, was not happy, went in with a pigtail across the TAVI valve, looked at the gradients, went back in with the wire, and only then I ballooned. So just because it doesn't look good doesn't mean you got to go after it. You know? So, see, the physics, I always say 99% of medicine is common sense, and for the 1%, I'll refer my patients to the brilliant doctors. Right? The physics is very clear. You have an AR enough to cause hemodynamic compromise. If you have an AR enough to cause poor quality of life, that's all you need to take another valve in. What you're trying to do is just to give them a better quality of life. I truly believe that in these octa and nanogenerians, mortality is accepted, but morbidity is unacceptable, right? So they're old, they're sick, they like to be independent. So if you see severe AR causing day-to-day limitation in the activity, causing repeated hospitalizations, one thing, as a corollary to your question, probably if the annulus is so far dilated that a 34 valve can't fit, then you probably can't do it. This patient had absolutely no calcium. Actually, I've scheduled a patient next week back home, and he's got no calcium at all. And I'm worried. But the one good thing about the valve that I've been using so far, which is the Medtronic valve, is that you can deploy the valve to 80%. And once you get the valve at 80%, you can take your catheter and you can push it and pull it a little, and you'll pretty much know how it's going to behave. In AR, you'll probably pull it out, but the beauty is you can capture it again, go back in. So what happens is with a little tug, if it pops out, then you catch him, go a little deeper, but we're all learning, right? So
I think AR is a totally different subset, and AR, which has some amount of calcium in the valve, is helpful.
Yeah.
The second thing is whenever you are choosing an AR patient, mix the valve area, the dimensions, you get it quite well with CT, with your echo. I feel CT is much better than echo in this case. The third thing is always go for a balloon expandable, self-expandable valve rather than a balloon expandable valve, because with a balloon expandable valve, there is a chance that the valve may embolize later on. Even the Gina valve concept is similar to the concept that Medtronic had once upon a time, the Engager valve, wherein you had clips that actually attaches to the leaflet. So if you can actually upsize the valve slightly, I think even in AR cases you can get along.
Yep. The key about this upsizing is that if you upsize it too much, the muscle will milk the valve out. And if you don't upsize it right amount, you'll have all kinds. So it's exactly. I guess we have to do more, and we have to, like Dr. Matthew always says about rotablation, right? Either don't do it or do it all the time. So that's
Thank
it.
you. Thank you, Dr. Satish, for that excellent talk.
Sure.
A nice discussion. Next, I would like to call upon our next speaker, Dr. S.K. Malini.
Good evening, ladies and gentlemen. Bring my greetings from Army Hospital R&R. And let me tell you, after these excellent lectures, we are learners. We have just done about 8 cases so far, a short series. And I would like to share my experience at our hospital. What I'm going to do is just take you through quickly the management algorithm as it stands now for severe aortic stenosis. The TAVI journey so far, just few slides only. The relevant trials, 1 or 2 slides. What I'm going to focus is on contentious issues, what excites us today. So as we know that you have 4 risk categories of patients of severe aortic stenosis: the low surgical, the intermediate, the high, and the prohibitive surgical risk. TAVR started as class 1 indication for the last category, and slowly we are moving towards low risk category patients. This is the 2017 IIC guidelines for management of severe aortic stenosis. We have 2 groups, that is asymptomatic severe AS and symptomatic severe aortic stenosis. And we have 4 options: either do nothing, medical therapy, which is going to go out now, and you have surgical AVR / TAVI. Risk assessment before the planning is obviously has to be there. The story, as we all know, first implantation 2002, and then we have come a long way from prohibitive risk, which was in the US core valve extreme risk study and in the partner trial. Everything showed that TAVR is better than SAVR in these category of patients. And of course, we progressed from this to the high risk category, where you had continuous partner trial and US core valve high risk study, which again proved that TAVI is better than surgical VAR in all outcomes. Then the indications expanded, and of course, intermediate risk patients were taken more and more for the transcatheter valve implantation. And now we have moved to low-risk patients. In fact, Dr. Praveen Chandra was here. He dwelt upon low-risk patients after the Notion trial and Medtronic low-risk trial, and we are on to the Notion 2 trial. And shortly, lower-risk patients and younger patients are going to come into the indications for TAVI. I'm not going to dwell upon the trials. Coming to the emerging indications, what we have now is low surgical risk patients, early interventions in asymptomatic severe AS, and even moderate aortic stenosis who present with heart failure particularly. There are two trials looking at this subset, that is the early TAVR trial and the EVOLVE trial, and these will give us some idea how to go about treating these patients at an earlier stage. Bicuspid aortic valve, already people have done a lot of cases in this category. Presence of severe AR and moderate AR, during the previous presenter, we had discussed this. Other associated valve lesions, when you have a significant mitral regurg and a tricuspid regurg, we know that once you do a TAVI, you can do percutaneous treatment for these valve lesions as well. Valve in valve, totally established now, and concomitant coronary artery disease can be again dealt with PCI. Now, what are the issues? Let's go one by one over that. Anesthesia. In our centers, what we have done is 5 cases general anesthesia and 3 cases under conscious sedation. But it's an institutional protocol. The access site, all femoral, generally femoral in most institutes. Now, the role of pre-dilatation is generally in 3 settings. When you have a bicuspid aortic valve, a very, very tight stenosis, and a severely calcified valve. Post-dilatation generally is done when you have a more than mild paravalvular leak. We have 2 main types of valves to be used today, that is the self-expanding or the balloon expandable. We have used all self-expanding valves in 8 cases. The durability of the valve is an issue because we do not have very long-term data as compared to the surgical AVR, but yes, time will tell us the durability issue. The next is timing of discharge. Now, in fact, very next day discharge is being discussed after TAVI. The only risk is that delayed AV blocks, which can come up, and the parameters to go by is that if you have a pre-existing wide QRS, right bundle branch block, or a post-procedural prolongation of the PR interval, they are at high risk. You may not discharge them. Role of cerebral protection devices, particularly to decrease the risk of the stroke. It's going to come up after a few more trials. The role of CT scan, particularly for valve thrombosis and degeneration. The adjunctive pharmacotherapy. Somebody asked in the audience, how do you manage them post-procedure? As of now, dual antiplatelet for 3 to 6 months, followed by single antiplatelet. But let me tell you, the latest edition of Braunwald has already said triple therapy for 1 month, followed by double therapy. How to address the issues what we are discussing? Feasibility in lower risk patients, the randomized trials are on. Device selection, again, head-to-head comparison between the devices may give us some answer. Bicuspid anatomy, some specific prosthetic designs may come up later on to deal with such cases. Durability, echocardiographic and 4D CT scan will help us in studying the durability of the device. Reduction of access site complications is also important, and as the delivery systems improve technically, it will be less and less. This is valve-in-valve expanding indications, what we have already covered. So as I said, we have done so far 8 cases, and all are doing well so far. First case was last year in November. The heart team approach consisting of cardiologist, the surgeon, vascular surgeon, and anesthetist, proper risk stratification, and explaining to the patient and relatives. We have trained one of the radiologists especially to carry out CT scans for TAVI. Most people were above the age of 75 years and with comorbid conditions and functional class 3 to 4. Baseline echocardiographic parameters, significant aortic stenosis, and trivial or no AR in all cases. All risk category intermediate to high risk category. The intra and post-procedure characteristics of these, mainly the size, evolute are 26, at 23 and 29, valve size were used. Pre-dilatation was done in 2 cases, and the gradients came down to 0 or within single digit. Only 1 case had 20 millimeter gradient. Complication, fortunately, no death, no major stroke. What we had is 1 atrial fibrillation, 1 retroperitoneal hematoma, and 1 acute arterial obstruction, which was dealt with surgically. At follow-up, 1 case who had severe LV dysfunction, EF of 30%, almost has improved to now 45%, and there are no significant gradients on the follow-up echocardiograms. This is just 1 case what I wanted to show, a simple, straightforward case of TAVI. The contrast-guided puncture is done on the opposite side from where you are going to take the valve. Idea is to puncture the common femoral artery well above the bifurcation point. You keep the pigtail in the non-coronary cusp and take a aortic root angiogram. Then, of course, crossing the valve, use JR or AL1, cross the valve, put a balloon-tipped temporary pacemaker lead, see the valve under the fluoro. You have a confida wire in the left ventricle. I'll just run through for the paucity of time. And once you are implanting the valve, you must be very, very accurate in your positioning of the valve. Removal of the parallax and, of course, device unsheathing. This valve is, of course, retrievable and repositionable. So up to 80% of the valve you can deploy and then have a check shoot. And if you are satisfied with the position, and then you release the valve completely. We are doing all cases under transesophageal echocardiography as of now. After the valve is fully deployed, you have the final check shot, very mild leak, and in the final shot you have of the access site. This is the case where we had a arterial occlusion of the access site, which was dealt with by our vascular surgical team, and the patient is all right after that. This is one of the cases where we had first case. I'll just show you that the important technique at the point of releasing the valve, if you are not careful and your movement of the wire in the LV is too much, the device may not seat properly and it may embolize. And if you see the second shot where it was being post-dilated, once the balloon was post-dilated, there was a rapid movement of the balloon up and down and the device got embolized. Of course, the second valve is put, and this is the final shot of that patient, which had a valve almost into the arch of the aorta. And I thank you for your kind attention.
Thank you, Dr. Malin, for that excellent presentation. And can I just ask you a question? In one of your cases, you told that the residual gradient was 20 millimeter. Usually, we don't leave the valve at that place? Because we tend to post dilate. What was the cause for that residual gradient in that case?
The residual leak was mild in that case.
No, gradient.
Gradient?
Yeah, 20 millimeter.
Yeah. So we had a gradient of 20 millimeter mercury, and either there was a mismatch with the size of the valve or something, but not clearly understood why the 20 gradients remained, because other cases we had almost zero gradient.
Okay. The second thing is, in the last case which you showed, the valve open valve was quite conical in shape, and while you were pulling out the nose cone, you should be really careful at that point of time. Absolutely. Pull on the, give a tug on the wire, and then only come out with the nose cone. Otherwise, the nose cone tends to pull out the valve. Probably that may have slightly pulled up the valve. So when you post-dilate this kind of valves, you are exactly at the annulus. If you post-dilate, there is a slight force setting, and the valve can easily pop off into the cusp. Any more questions from the audience? Any question from the panel? Thank you very much.
Thank you very much.
So we move forward to another presentation by Dr. Anup Agrawal, and it says saving lives one at a time. Dr. Anup has been trained in US. He used to be in AIMS when I was doing my MD residency. He was doing his MBBS in AIMS. So Dr. Anup Agrawal.
Thank you all for inviting. Can I have my slides, please? So the sides of the slides are a bit cut off. Okay, let's try and see if we can work with this. Good afternoon, everybody. At this point, most of what I'll say will be repetitive, but we'll just quickly cruise through it, and then I'll show you a case at the end. I don't have anything to disclose right now. Whenever we have a new therapy, particularly TAVR, now we shouldn't be talking it as new. It's been there for about 7-8 years now. We always want to substantiate a therapy based upon its biological, scientific, and clinical validity. Biologically, to this audience, I don't have to tell them, aortic stenosis puts up a lot of stress to the myocardium. That causes increased wall tension and preload dependence, due to which if we have to relieve the aortic stenosis, then the myocardium is much more happier. It also has effect on the coronary flow. It increases the early systolic deceleration. At the same time, it decreases the systolic acceleration, both in terms of the coronary flow physiology is disturbed, and that certainly precipitates angina on the top of LV wall tension. Physiologically, it makes sense to relieve severe aortic stenosis based upon what we just talked about. The other concept about afterload reduction, that is again something that has that we all are very familiar with. It's a therapeutic target for a lot of our situations: mitral regurgitation, LV systolic dysfunction, and acute MI. But lately, we have been understanding that the afterload reduction does not just have to be a systemic vascular resistance. In fact, now we are talking more about the global hemodynamic load rather than just the afterload. And if we dissect it out, it can be summed up as a combined effort of systemic arterial hypertension, as well as whatever load the valve offers. Both of it makes up to valvular arterial impedance that certainly increases the LV systolic pressure, wall stress, coronary perfusion. So far, so good. Now, if you have another problem associated with it, be it in the form of coronary artery disease or LV dysfunction or whatnot, now that triggers a whole cascade of dysfunction, which may lead into LV dilatation, systolic dysfunction, diastolic dysfunction, eventually leading to dyspnea and all the symptoms that we are very well worried about. So our all medical therapy is very well just adjusted to systemic arterial hypertension treatment. But if we start treating moderate aortic stenosis, that also will be one way of reducing afterload, and that is the unload trial design, where the therapeutic target is moderate aortic stenosis in a patient with a compromised LV systolic function in an attempt to decrease afterload mechanically. So that's another place where TAVR certainly has a role on it, and it passes our biologic validity. Scientific validity, there had been a lot of presentations which had been done so far. I think it is fair to say that very few medicine advancements at this point of time can boast of the robustness of data that TAVR can. And I'm just putting up some of these slides. Most of it is repetition. but we'll quickly go through for the completion's sake. This is the very first randomized trial, partner 1, cohort B, which is extreme surgical risk. Very good endpoint at the end of 2 years, and the therapeutic target was maintained at year 5 as well. Same thing was with the high-risk patient in using core valve. Intermediate risk using core valve in CERT-IV trial. Notion was an all-comer trial, which now has a 5-year data as well with an average STS score of about 3. This is so far the best trial that we have for the low-risk patient. And there also the therapy looks very, very optimistic, particularly related to stroke, where numerically TAVR performed much better. And this was using the early generation TAVR platform, not the SAPIEN 3 or the Evolute R or Pro. So all in all, scientific validity is very, very good. The robustness is there. When we talk about the clinical validity, essentially what we want to say is that, okay, makes sense, it has got good data, but how it translates into what I do. And that is where I am going to put up one case here. We'll go over this. This adds to the point what TAVR can do, what armamentarium it brings to our cath lab. So this is a patient who is 81-year-old male, past history of non-ischemic cardiomyopathy with an EF of about 35%. He has a history of diabetes, hypertension, and a CKD with a baseline creatinine of about 2.5. He presented to us originally with class 4 NYHA dyspnea, and echocardiogram at that time revealed severe aortic stenosis. So I'm talking about August 2017. That was his first admission, where he had a class 4 symptoms, improved with medical management. He did have acute kidney insult at that time, but that improved significantly. At that time, surgical evaluation for surgical AVR was considered, and the plan was for outpatient follow-up. Now, things weren't that bad at that time. That was the first admission. His duration of stay was just a couple of days. Literally within a few weeks, he gets readmitted with heart failure. This time, he had acute viral illness, which precipitated this heart failure, and this time it was relatively significant. Acute cardiac decompensation, he required inotropic support, prolonged hospitalization, almost about 2 weeks. Surgical evaluation for AVR was done at that time. And here is his STS score. For all of us who do calculate the numbers, here's what I want to churn out. His risk of mortality, based upon the clinical parameters I gave you, is 56%. I don't think surgeon will even enter his room, forget about even evaluating. We started discussing about TAVR, which to our institute at that time was relatively newer technology. Barriers were unfamiliar procedure to the family, high cost, of course. And then there was this hope that maybe the current hospitalization was precipitated by viral illness. So once the viral illness gets better, maybe he will get better and his risk score for SAVR will go down. And we discussed BAV as a second option if it does not improve. He got discharged. It just so happens, I was visiting US for a conference. That is when his daughter-in-law, who is a doctor, messages me this, that my father-in-law is admitted in ICU again for CHF. This is his 3rd admission, and now family is pretty much set for TAVR. So this is October 16. This is his index admission, 3rd admission consistently for the last 3 months. Now he's in bad shape. Oliguric on 2 inotropes and vasopressors. He was started on ultrafiltration for volume management, and that is consistently a problem because his pressures hardly reach 90. He decompensates with each paroxysm of atrial fibrillation that he's having. He has significant end organ dysfunction, including pretty much everything: kidneys, liver, lungs, brain, intestine. We were talking about survivability, whether this guy is going to survive. His LV dysfunction was deteriorating every time. This is his ECG with normal sinus rhythm, prolonged PR, and a left bundle. Even with an EF of about 20-25%, he was generating velocities that were reaching up to 4 meters per second. At that time, TAVR was not something that was on our shelf. I don't think that the valve is on our shelf anyways. So we had to bridge something before we can get TAVR onto it. So we planned for percutaneous balloon aortic valvuloplasty while we set for TAVR. We used a 20 millimeter balloon. His mean gradient, we were able to get it down from 44 to 32. For the dilatation, we couldn't do it because he started developing aortic regurgitation, and we had to pretty much stop there. And then we had to take him for urgent TAVR. This is a standard CT assessment that we do for all of our TAVR patients. This is again something which we are quite familiar with. The numbers speak for itself for measuring. We know that now CT-guided measurements are far, far better than any other assessment tool that we use, particularly 2D echo or transesophageal echocardiogram. Tricuspid valve with some amount of calcification. This is our friendly calcification, the right amount of calcification that we need, not too much, but certainly if there is no calcification, it creates trouble for us. Coronary height are very optimal. Implant angle was quite optimal. He has got a touch of dissection on the right common iliac side, but the lumen was nicely maintained. Same on the left. Overall, the summary of the numbers. We always do an ultrasound-guided 4 French puncture, and when we are satisfied with our site, then we upsize it to a 6 French sheath, take a repeat shot of the groin, make sure that we are exactly where we need to be. This is our primary access site, and we are 100% percutaneous. And after that, the procedure itself was relatively uncomplicated. The valve goes in very nicely. It's a relatively friendlier valve as compared to the earlier generation core valve that used to jump a lot. The implant itself was quite unremarkable. We were quite mindful of the amount of contrast that we were going to use, given the fact that he had a new need for dialysis, and we wanted to give his kidneys the best shot to come out of it. The valve was plated. It was post-dilated because of high gradients post-procedure. Here you can see at the very end, we always do a DSA of the groin. In his case, we just did a 5 ml shot to make sure there is no any obvious leak. It was a double pro-glide closure with no any obvious problems. Peri-procedure, we used about 20 cc of contrast in this entire procedure. He was on noradrenaline at the beginning of the procedure. After the procedure, I asked my anesthesiologist how much noradrenaline he's on now, and he told me he had to maintain his pressures. Now he had to put him on nitroglycerin infusion. He was extubated the next morning. We typically get the patient extubated on the table itself. He was relatively sick, so he had to put on rest for at least 24 hours. His systolic pressures have been maintained for more than 120 millimeters consistently. This is another power of TAVR. It's kind of it's not a very scientific title, but it rhymes. The procedure was done on November 8th, and you can see this is less than 24 hours. This is the message that I get. Just had a video chat with my father-in-law. He looks great. That's the kind of power that this therapy offers to us. This is the patient within 12 hours of the procedure. You can see he's giving us a thumbs up. 12 hours before, we were doubting his survivability for that admission. He had marked improvement in symptoms with dialysis. He was out of ICCU within 48 hours of procedure, and he very soon walked 200 feet after that. He was discharged on day 6. He had been off dialysis on week 6 with a baseline creatinine running around 2 now. It's been 7 months since TAVR. He had no readmission for any other ailment. To summarize, aortic stenosis of any degree contributes to left ventricular afterload. We have to identify what are the right patients where we can offer them mechanically reducing their afterload. High quality clinical data supports the use of TAVR. Now it's a standard of care for intermediate, high, and extreme surgical risk. Any patient with reduced sternotomy and valve-in-valve cases. TAVR not only adds quantity of life, but also quality of life. And that is one of the most important message I want to take home. This train has left the station. Thank you so much.
Thank you, Dr. Anup, for that elegant presentation. It was nice to see that you could do with such a low contrast. Actually, TAVR, you don't need so much of contrast. And particularly if you have a low ejection fraction, then you can see everything quite clear. Or you can just pace for some time. In that case, you can even further decrease the amount of contrast you want. The final contrast you want definitely for your paravalvular leak or not. Any questions from the audience? Any question from the panel? If there are no questions, thank you very much.
Thank you so much.
Dr. Anup. The next presentation is by Dr. Rajneesh Kapoor, who is the course director as well as the organizer of this conference.
Well, just a comment on Anoop's wonderful talk. I think that was pretty wonderful to listen to you, Anoop, for the first time. So I have seen a case, and operators doing a case without a contrast, on T-guided, totally. So that's something newly coming up, although I feel it's, small contrast, we finish the procedure, that's always good to know that what's happening. So, but I'm just mentioning that operators have done TAVR without a ml of a contrast, just T-guided in such situations. So I'm here with my data. Personally, I have done 9 to 10 TAVRs up till now. So this is one challenging case which I shared and presented in Dr. Mathur's meet also last Sunday. So 2-3 complex cases out of these 9 to 10 cases. This was one. So one challenging thing in TAVR, obviously, the chances of occlusion of coronary ostia, especially the left side, and especially if the coronary ostial height is lower. So that is one thing which, can complicate the procedure and can lead to nightmare in cath lab if you are not well prepared or if you haven't really well planned your case. So it's very, very imperative, very essential really to know the actual parameters millimeter by millimeter. This is very, very essential, and many of the operators do the dimensions, measurements themselves. They do not really believe on the CT guys, and they do it by themselves. I think this is pretty good. So we should know exact things. Now, as Sai Satish was also mentioning, doing and executing a TAVR is not a very big deal. It's a planning. So once you are well planned, I think 97% chance you will come out successful. You should know exactly where you are going to place, what's the height of coronary ostia, I mean, is there any chance? If there is a chance, how to preempt the solutions. So this is one of the cases in that line. This was a 74-year-old lady with critical aortic stenosis with bad lungs. So surgically refused for surgical AVR. Definitely she was not a good case because of that. So planned for TAVR after discussion with the whole TAVR team. This slide may not be very descriptive, but see the red markers. The red markers is the coronary ostial height on the left side, it's 9.2, pretty borderline. So whenever it's less than 10, I think that gives us, our adrenalines start rising as an operator, that we should know. First, we should plan that, how to do it, and if at all there is a problem happening, we should know how to circumvent that. Now, in order to do that, to do a case meticulously, we should exactly know what size we are using and what's the height of the valve, what's the skirt height, and how much down we are starting the valve. So in this case, it was a 23 millimeter evolutar. This is the various dimensions. This is a case, obviously a fluoro-guided puncture. Dr. Anoop mentioned about 4 French, access. That's a US technique, I think. So as is US trained, so I was also in US for 10 days for various TAVR centers. So they typically do it with a micro needle, and then once they are certain, then they upgrade it to the 6 French or 7 French later on to avoid the vascular complication. This is a good way, even I believe. So access and a pigtail in aortic root, valve crossed, a confida wire, and a balloon aortic valvotomy with a 16 balloon here. Now this is important step here. I'm just figuring it out. So once you are dealing with a low coronary ostial height, this is a very important step. While you balloon dilate the valve, do the aortogram and see what's the positioning. Is it towards the left coronary sinus? Is there a space there? Now this is 16 balloon. Now you should know exactly, if we're using the 23 valve, approximately at this point, the width of that valve would be 20. So is it a 4 millimeter or more here? And then, so this gives you an idea. This gives you an idea that how does it look. You can also upsize the balloon little bit if you are in doubt, to know that whether there are more chances of occlusion. Now in this case also, I forgot to mention, the problem was not only the coronary ostial height, problem was the sinus of Valsalva width, diameter of sinus of Valsalva. That was 25 on the left side. So it was again borderline. Now if the coronary ostial height is low but sinus of Valsalva is voluminous, I think then still there is not a big issue. The valve is not going to jump towards the coronary sinus and occlude it. So in this case, both were borderline. So this step is extremely important while we plan it, and then obviously the execution. So we are using the self-expanding, especially in such cases, because at 80% it's retrievable. We go up till this point and again look at that. You know, again give a aortogram, do a aortogram at this point and gain good time just to see what's happening. So this is what I am trying to say. So this is the aortic valve which is coming up till this point, and if you see the plane of coronary ostia is different. So even if once it acquires more width, once it is fully open, and it looks like that it's not going to hamper the coronary ostia. So this is again important, and if we are more in doubt, we can take out that valve and plan either slightly further down or change your strategy. So these points are extremely important. Now, also if we are more in doubt, we are ready with the troubleshooting, the solutions, the guiding catheter can be engaged, the wire can be advanced into the coronaries and stent can be just placed in the coronaries, that if need be we withdraw the stent and deploy it to actually circumvent this problem. So, since up till this point we were thinking that we are going safe, so just went ahead and deployed the valve, and to our luck we were absolutely fine. This is the final positioning, and I'll show you the aortogram post valve. So this is how it looks. The coronaries are flowing good. The lady is doing fine. This is around 3 or 4 months back. So this was one case which I showed, worth showing it here. One more case we have done last week only, which was highly calcified bicuspid valve, like the case which Dr. Sai Satish had shown. Some of the points there also, but I'm not carrying this case here. Thank you very much.
Thank you, Dr. Rajneesh, for these excellent presentations. And yeah, planning in TAVI is utmost important, because that is where you decide where you are going to take the puncture, what is going to be the size of the valve, how deep you want to go, how high you want to keep. In this case, it was a well-planned procedure because the sinus of vessel overall was less than 25 millimeter, which as such is at risk for coronary occlusion, because most of the valve, the whole diameter after it opens, it tends to occlude. The second thing is the low coronary height. 9 millimeter is quite borderline. Maybe that is the reason why it got just along. If the sinus of vessel is quite voluminous, the coronary filling occurs in diastole, so it is very easy for the coronaries to fill. So 99% planning, 1% execution in TAVI. Any question from the audience? Panels? Thank you very much. So we move on to the next presentation. Dr. Ajay Kaul is a very senior surgeon who works at BL Kapoor Hospital, and he will be talking on the importance of heart team in structural heart disease program.
Good evening. I am probably the only surgeon in this audience, and I'm going to discuss about the heart team. Now, managing patients with very complex cardiovascular problem has changed substantially in last few years. We have more sicker patients, we have older patients, and we have patients with lot of comorbidities. And there is a huge amount of data that is available with us now. It is important for us to explain this to the patient along with interventional cardiologist, the surgeon. Patient has various options now. It's not only the intervention that is possible. We have various other things with which we can treat the patient. And heart team is at the core of all this. And there are no options. We have to have a heart team in our hospitals. There is no solution for this. And it has been pointed out in various organizations that you need to have a heart team and it's a class 1 indication now. Till now, coronary artery disease was the commonest disease, and we used to treat it with medical management or interventions or surgery. These were the options. But now, with structural heart disease also coming in, now we have various other options. And now, do I have any disclosures? Yes, I am a surgeon. So I have lot other things available. A cardiologist will tell the patient, okay, there is one option, and that's the importance of the heart team. What are the options? Suppose I talk to a patient. I have my colleagues, Dr. Chandra is there, Dr. Bhalla is there. We have a large team. So first option, and telling this medical management doesn't have a role today, I don't think that is true. There are some patients who are extremely high risk for surgery and can't afford the interventions also. So they are the ones who should be treated properly on medical line of management. Second would be transcatheter interventions. Midline surgery is what we have been doing all these years. Minimal access surgery is again a wonderful thing and does good to the patient. We have another option, and that is called sutureless valve. This is the same TAVR valve but used surgically. We have robotic surgery and we have hybrid procedures. Now look at this. This is a patient who has undergone aortic valve replacement through a small incision here. Now the morbidity is very small in these patients. Instead of cut, let me tell you, around 90% of our patients now, valve replacements, are done minimal access. We don't do large cuts on the chest. Then, as a surgeon, where we have wonderful team of cardiologists along with us, this, see, there are various options available for the patient. So it is very important to tell patient about the options that he has now. Let's not go only for interventions. This is a patient who had come from Africa. She had aneurysm, ascending aorta, transverse arch, and descending thoracic aorta involving abdominal vessels. This patient was discharged in 3 days. What we did first was I took this patient to the OT, and we did a side graft here, debranched all her neck vessels, then put a stent graft here, and then branched the abdominal vessels. Why I brought this here was just to show you that a hybrid procedure is also one of the very good options for these patients. Now, so far as cannulating these arteries are concerned, we have been doing this for ages, and we don't have the luxury of cath lab. I do these under TE guidance. We first puncture the femoral artery, put the guide wires, and then shove in 24 size catheters. So you can imagine these are huge, and we have very few complications of peripheral vessels because we are very careful and we have been doing this for years. You can understand another thing. There is a cannula here. We have been cannulating carotid arteries, and believe me, carotid arteries are larger in size than femoral arteries. Less calcification. So that's also an equally good access. This is another child where we have cannulated. This was a child who was brought to the hospital with viral myocarditis. We didn't get femoral access, so we have cannulated carotid artery and jugular vein. And this patient was on mechanical heart support system for 45 days and then sent home. What I want to emphasize is there are various other cannulation sites. Take help of your surgical colleagues and they will do wonders. Now, let's come to the aortic stenosis. It's going to come in a big way. There's no doubt about it. And we know that there's no problem about the high-risk cases. TAVR is a brilliant option for these patients because you can't do surgery. My worry is about these patients. Also not about intermediate cases. Yes, you should give patient a choice of surgery, minimal access surgery, sutureless valve, or TAVR. My worry is about these patients who are extremely low risk. Once this option is there, we may misuse this procedure. We have to understand who are the patients who should not go for TAVR. Now we assess surgical risk of these patients. Now let me tell you, besides STS score, what is also important is these criteria, and very significant among this is the frailty test. It's very important. On surgical evaluation, we don't do normally frailty test. And then we classify our patients into low risk, intermediate, and high risk. Now, surgical technique has matured over years. For the last 25, 30 years, we are doing surgical valve replacements. TAVR is young. We have recently started doing it. It's a wonderful procedure, and really, Amit is here. I'm one of those guys who promotes this and wants as a surgical team, should be doing more and more TAVRs. But I'm very careful. SVR, that is surgical SAVR, is driven by technique. Let me tell you one thing. If a doctor joins my unit and he says, I put in 5 years of surgical training after MCH, I will not be confident of giving him an aortic valve replacement, because it is not so simple. It's a very complex thing. But for TAVR, it's a different story altogether. You have seen guys who have done just 10 cases, 8 cases, 12 cases, and after that, many of them can do independent cases. It's not true about the surgical procedure. So surgical procedures are complex procedure. What I don't like about surgery, I'm a surgeon. All my life I've operated. What I don't like about surgery is midline sternotomy, heart-lung machine, and anesthetist. My friend is there. I don't like them, because if a patient goes on ventilator, you have all sorts of problems. Best is to do any procedure under local anesthesia, and that's, or awake sedation. And how do you compare the surgical procedure? It's like CTO. We have been seeing all these presentations going on. Similarly, it's like CTO is a complex procedure. We had a conference of Dr. Atul Mathur recently, where we had seen these thoracic abdominal aneurysms. Very few people do it, and they are still struggling. Same is true about surgical procedures also. You find these cath labs in far-flung areas where they are doing a brilliant job, but not the surgical team there is still struggling. So surgery is complex. So my predictions for 2020, we always say that which cases are bad for SAVR, they should go for TAVR. But it will be the other way around. We'll ask which are the cases which cannot be done by transcatheter, they will be referred for surgery, and it is going to come. Now, there are lots of adverse or problems with TAVR, but I'm not worried about these, because I know that this will be dealt with, because billions of dollars are being invested into research, and we will overcome all these problems. Life-threatening disability, bleeding, acute kidney injuries, I'm not worried about this. Delivery system, femoral complications will come down, because these devices can be delivered through very small sheaths. So that's also not the problem. My concern is only about one thing, and why I'm telling you this is durability. This is very, very important. At the moment, we are not understanding that tissue valves, we don't touch tissue. If I find my junior doctor just handling the valve or touching the leaflets, I throw him out of the OT, because it is not allowed. You cannot. And we crimp this valve so badly. I really don't know what would be the long-term results. I'm not telling you that it's not a good technology. It's a brilliant technology, but we have to be very cautious about it. Now, let's come to the sutureless valve. Now, you just see this valve. This is exactly the same tissue valve, the TAVR valve. It's a nitinol stent. It's crimped. It's a bovine pericardium. This is the other one. I'm not getting the point. This one is Intuitive by Edwards. These are both same valves. The other thing which I realized, we have one of the largest number of sutureless valves in the country, which we have implanted at BLK Hospital. I always wonder, in this, before implanting a sutureless valve, we remove every piece of calcium, and then it's a self-expanding valve. We don't, the other one is balloon expandable. This is a self-expanding. We don't take any stitches. So I am sure that in future, and since there is no calcium, nothing, you know, there are two reasons for this. Why we remove the calcium? Because the principle is that if you don't remove the calcium and there is slight kinking of the leaflet, or the leaflet doesn't open properly, that is the place where there will be turbulence, and turbulence leads to degeneration of the valve. It's very important. So I really don't know what will happen to those patients where the calcium has been left there, a blob of calcium is there. Besides paravalvular leak, the turbulence is also very important, which can lead to degeneration of these valves in future. So at the moment in my unit, I used to follow TAVR, and then for high risk sutureless valve, it's come down to medium risk also. This is how the valve is implanted. It takes just 3 minutes to implant the valve. It's pretty quick and good. But yes, the good thing about TAVR is no heart-lung machine, no anesthesia. Whereas in this, we require heart-lung machine and anesthetist. Now, what is the effect of crimping? crimping of the valve leads to, you can see this. The last one shows massive damage to the tissues by crimping this valve. So this is my concern. So my concern is only about durability. Otherwise, it's a very good technology and should progress. And this is a very famous slide. You can see this, it's from those patients who have died due to some reasons. And you can see this is within 5 years, some of the leaflets have degenerated. So be very careful. Let's not keep on putting it each and every patient. Surgical technique is still the best. So now, in my practice, I have shifted sutureless valves to low risk also, because these are the tissue valves where we respect these leaflets and don't crush them. There is an explosion of TAVR. It's going to come for low risk also. My concern is, again, durability. There are 2 valves, 3 valves at the moment being used. Of course, femoral access is a problem sometimes, but I don't think we can easily overcome. I'm really scared of this complication. This is dangerous. You lose patient in seconds. I'd never seen this complication in spite of some 500-600 peripheral cannulation, but in the cath lab, 1 case, and I'm still terrorized. The benefits of TAVR are huge. I mean, it's one of the best technologies you could ever have. And in conclusion, I am all for TAVR, but be very careful because the durability is still a concern. Thank you very much.
Thank you, Dr. Kaul, for that excellent presentation and comparing the two kind of technology. There are few, obviously the few questions raised are pertinent to the present day world, but let me just tell you, the longest follow-up I have done for any TAVR case is 11 years old case. And these cases were all 84 years. I followed them up until they were 95, and they had no problem. Of course, this cannot be extrapolated. The second thing is we have always crimped the valve, and post-crimping there has been enormous number of studies by oscillating the leaflet at a higher frequency to see how far the valve can go. And they have not shown any kind of deterioration in comparison to the bioprosthetic valve. The third thing is, of course, sutureless valve looks quite interesting, but still you need to go on heart-lung machine. And this is where the TAVR, I suppose, has an edge over it. The other thing is the leaflet, of course, what you showed at the end, that is because of the thrombus. Now we are starting to get worried about thrombosis of the TAVR valve, which is seen by 4D CTs. But let me tell you, all these patients we have been keeping on dual antiplatelet from the initial days, because these are very fragile patients. You cannot put them on another anticoagulant and just add risk of intracranial bleed. So no trial was done, but as we are moving towards the lower risk, probably we'll start adding anticoagulation too for certain duration of time. As in surgery it is done. For 3 months we give acetrom or warfarin. Anyway, it was a great presentation. Any question to Dr. Kaul is welcome.
Amit, if you allow me, can I ask one question? I'm really worried about one more thing, and that is, see, these are my concerns because we have been implanting tissue valve for ages now. We put on acetrom at least for 3 months, as you rightly pointed out, and not on dual antiplatelets only. And recently, I enjoy, when I go to cath lab, I've really started enjoying now. There was a patient who had come with tissue valves, and I have now 5 patients who was not put on warfarin due to whatever reasons, and they have come with early degeneration. And when I went inside in one of these cases, operated, I didn't have to do much. I just opened this valve and it opened. So next case, Amit Pendarkar is here. We took the patient to the cath lab. In fact, I was scared. We opened with 16 balloon. I tried my best. I said, okay, now. Then I called Dr. Bhalla, who inflated it with a larger balloon. I was worried about the regurgitation, and the valve opened, and it was 0 gradients. So what I want to point out is, acetrom not being given to the patient can be a cause for concern in future.
Yeah, exactly. That is the thing, like degeneration or whatever. But the case you were pointing out, I would have better given acetrom for a longer duration and seen if the if the valve opens up, because most of these cases are because of thrombosis, which are well seen on 4D CTs. We cannot see on a normal CT. So in these cases, we have experienced this on TAVR patients, and there is a publication, beautiful publication that was published in JACC intervention, I think, and that showed like the least thrombosis rate is in balloon self-expandable valve, followed by the balloon expandable valve. So probably when we move towards intermediate and the low risk, we will also start adding some amount of anticoagulation to this patient, as rightly pointed out by you, and that concern is well taken. Any more questions to Dr. Kaul, please?
I thank the organizers for giving the
Thank you very much.
Thank you.
So we move on to the next presentation by Dr. Radhakrishnan, who will be talking on percutaneous pulmonary valve implantation.
Thank you. I want to thank Dr. Rajneesh for having invited me. Percutaneous pulmonary valve, I must admit that I don't have much experience with this. We have just started. It is a procedure which has just started in the country. But I'm going to talk about the scope of percutaneous pulmonary valve in the current era. Clearly, if you look at the number, you will be ridiculing us compared to what we see for the TAVR procedure. So the first thing, it was started in 2000 by a cardiologist, pediatric cardiologist called Philip Bonhoeffer, as an alternative to open heart surgery to prolong survival of the RVOT valved conduit. Since then, multiple studies have documented the short-term benefits of transcutaneous pulmonary valve implant. It has, of course, the advantage of avoiding open heart surgery, and most important thing is the much smaller pool of patients compared to TAVI, but gradually it is increasing over a period of time. There are three subsets of patients who undergo percutaneous pulmonary valve implant. One is the patients with conduits in the right ventricular outflow tract, typically patients of ventricular septal defect, pulmonary atresia, truncus with conduits, TGA VSTPS with conduits, and the post-Ross procedure, which has a homograft on the pulmonary side. Currently, this is the largest subgroup of patients, and the approval, FDA approval or the EC approval, is only for these group of patients. The second group of patients are patients who have a prior pulmonary valve replacement, especially the tissue valve replacement. So it essentially becomes a valve-in-valve procedure. And the third one, which is the most challenging, is trying to implant a pulmonary valve in the native right ventricular outflow tract. These are patients typically who have been repaired for a tetralogy of fallow and allied lesions with a transannular patch, and now they present to you with free pulmonary regurgitation with or without a minimal degree of obstruction. And they are gradually increasing in number, because remember that these patients have been operated about two decades ago, and now they come to you with an effect of pulmonary regurgitation. So it has the potential to be the largest pool, but now it is one of the smallest pool of patients that we have, because there is a lot of challenge in trying to put a pulmonary valve implant in a native RVOT, which is typically very dilated and sometimes aneurysmal. So the patient population are the ones with the post conduit. Typically they have these bovine jugular valves which has been implanted, the Contegra valve as it is called. Some of them have the homograft, and typically the size of the homograft of the bovine jugular valve has to be a minimal of 16 millimeters in order to implant a transcatheter valve. So typically children or newborns or infants, so to speak, who have had these procedures will have to have a second surgical procedure in order to implant a bovine jugular valve which is at least 16 millimeter, or a homograft which is at least 16 millimeter in size. So it would probably be a third procedure as far as the child is concerned, because if you look at the data, truncus arteriosus patients typically have their surgery at 2 or 3 months of age. TGA VSTPS patients have their surgery by about 6 or 7 months of age. So they are not going to have these big valves inserted in them. The post valve implant typically requires an adult size valve, which should be more than 20 millimeter, which can actually be broken. When I mean broken, I mean it has to be balloon dilated So these are typically the peri-mount valves. As compared to the Carpentier-Edwards valve, which is also implanted nowadays, that it has a stiffer frame and it cannot be broken by a balloon technology. The reason for breaking it is to create a wider bed so that as big a valve can be implanted. Native RVOTs are always dilated, so there is a need to create an appropriate bed in them by staged stenting in order to shrink the RVOT so that an appropriate valve can be implanted. So in all these cases, it is a different strategic approach. What is the current situation now? The AHA statement in 2011 states that it is reasonable to consider pulmonary valve replacement in patients with right ventricular to pulmonary artery conduits with associated moderate to severe stenosis or regurgitation, provided the patient meets the inclusion and exclusion criteria of the valve available. It's still a class 2A indication with the level of evidence B. They have not recommended yet in the pulmonary flow for native right ventricular outflow tracts. And typically the clinical indication is when there is a pressure overload of the right ventricle, when the conduit gets stenosed and degenerated. Then there is this group of patients which I was mentioning who present with volume overload, which is still not an established technique for a pulmonary valve implant. Typically they still go for a surgical correction and a surgical pulmonary valve replacement, but the scenario is likely to change over a period of time. This is the valve which is now used for transcatheter pulmonary valve replacement. It's called the Melody transcatheter pulmonary valve. It is an 18 millimeter Contegra bovine jugular vein with a valve, and it is mounted onto the CP stent, which we commonly use for treatment of coarctation stenting. So these are the sizes that are available. The 28 millimeter length shrinks into 22-25 millimeter at 20 to 22 millimeter balloon size. It is typically crimped down to 6 millimeter and then re-expanded to whatever size that is necessary. These are the delivery system. It's called the ensemble delivery system. Basically, it's a bib balloon again, a balloon in balloon, which we use for coarctation stenting, which has a retractable sheath which is carried right up to the pulmonary outflow tract before the sheath is retracted. And the three balloon sizes over which it can be crimped is 18, 22, and 24. So typically, you cannot put a transcatheter pulmonary valve when the outflow tract is more than 24 millimeter, unless you create a bed in that particular area in order to implant the valve. Then, of course, we have borrowed from the adult technology. For certain cases of right ventricular outflow tract, they have now started implanting the Edwards Sapien 3 pulmonary transcatheter heart valve, available in 3 larger sizes, typically when the right ventricular outflow tract is big. So we have a 23, 26, 29 millimeter sizes. I don't want to talk about it. It's the same as the Sapiens valve which we use for TAVR procedures. We have this venous valve which came into vogue recently, about 5 or 6 years ago, but then it has been withdrawn from the market and they are doing re-studies in Europe. This is a self-expandable multi-level support frame. It has an integrated tri-leaflet porcine pericardial valve tissue, and the entire system is covered except the distal third by a porcine pericardium. It has a smaller delivery catheters, and the advantage is it's available up to 32 millimeters. So when this comes back into the market, probably it will be very useful for patients who have large right ventricular outflow tract, typically patients with severe pulmonary regurgitation. Currently, it has been withdrawn, and they are again trying to do some studies in Europe in order to check the feasibility of using this venous valve. There are 1 or 2 centers which use this venous valve in India, but then it didn't work out well with that particular model. So what is the pre-procedure evaluation? We have to do an echo and MRI are important in determining the right and left ventricular functions and dimension. Echo to assess the right ventricular outflow tract gradients and dimension. The magnetic imaging is to assess volume, regurgitant fraction, and various dimension, and in some cases CT to image the right ventricular outflow tract and coronaries. So this is the typical view which is taken, the parasternal, various dimensions are made. Of course, we don't rely on echo nowadays. Most of these patients are grown up, and echo is never going to give us a proper image, except, of course, it quantitates the degree of obstruction across the right ventricular outflow tract. This is the current technology which is used, and we make these measurements before we finally decide whether we can go ahead with an implantation of a transcatheter pulmonary valve. There are certain contraindications. If you look at this right ventricular outflow tract, it is horrible, bilateral peripheral pulmonary artery stenosis, and an aneurysmal dilatation of the right ventricular outflow tract. These are contraindicated for any technique. A balloon interrogation of the right ventricular outflow tract is absolutely necessary to assess the size, stretchability, and likelihood of fracture of the conduit. At the same time, aortogram or a selective coronary angiogram is absolutely necessary after balloon inflation of the right ventricular outflow tract to assess relationship of the coronaries to conduit, and also to assess the potential compression of coronaries by the expanded conduit. Remember that this occurs in about 4.4% of cases, and if you don't do it prior to the implantation of the transcatheter pulmonary valve, then you are going to lose the patient on the table. And if it is present, it is an absolute contraindication for a transcatheter pulmonary valve implant. The procedure has to be aborted if you demonstrate a coronary compression during the right ventricular outflow tract dilatation and a simultaneous coronary angiogram. These are the measurements again which are taken during the angiogram and before we plan the procedure. ASD balloon size up to 34 millimeters is chosen to decide whether a pre-stenting is necessary or not. And this is one example of a patient who had a balloon dilatation of the right ventricular outflow tract and a simultaneous coronary artery angiogram, and you can see how the LAD is compressed. You have to immediately back out, and the patient has to go for a surgical treatment. So this is how these things differ from a TAVR procedure. A much more greater preparation is necessary, and not all patients can be suited for this particular procedure. Now, pre-stenting of a conduit, a pre-existing conduit, has now become almost mandatory. And now the data is just now available with us, because if you don't pre-stent the conduits, the incidence of fracture of the Melody valve is extremely high, to the tune of about 30 to 40% over a period of 3 to 4 years. So now they have decided that even if you have a bed, like a conduit already present, you just don't go ahead and implant the transcatheter pulmonary valve. You actually have to pre-stent it, and typically you pre-stent it with a covered stent, because most of the time these conduits are calcified, they are friable, and if you just do a bare stenting, then it can rupture the conduit and the patient can collapse. So they do use a bare stent, but the trend is now to use a covered stent. So it provides an adequate landing zone. It ascertains the absence of coronary compression, and there is a greater margin of safety, which is more critical for SAPIEN, which is a balloon expandable stent, and to avoid late compression of the stent and late fracture of the stent. So this is one example of a patient who had multiple stents placed in the right ventricular outflow tract in order to support it, and then we go ahead and implant the transcatheter pulmonary valve within this. The complications have all now come to less than 10% now. Various complications very similar to that of transcatheter aortic valve. And these are the early and mid-term results. It is almost embarrassing to see the numbers that are present as compared to the TAVR procedures, which goes on to thousands and thousands. We are still in the hundreds for the data to emerge. And the overall freedom from re-intervention at about 3 to 4 years is approximately 76%. So typically these valves are not likely to last for a very, very long time from the data that is available. But look at the numbers. The maximum is, I think, 170, and look at the number of TAVRs that are available. So the freedom from re-intervention after a transcatheter pulmonary valve depends on the follow-up time. And it is about 90, 80, 70% at 1 to 2 and 4 years of observation. And the year freedom from explant is approximately 92%. So that's a very acceptable result that we have in the pulmonary valve position. Now, there are certain features of transcatheter pulmonary valve implant. We are using what is known as the RVOT reducing, RVOT reducer as it is called. So instead of stenting, if you use the RVOT reducers, we might be able to implant them in a longer time. So this is a patient who actually had a tetralogy repair, which I am going to demonstrate now, had a BT shunt. Typically, this is the demography of them. They have a BT shunt in 2000, a total correction with LPA-plasty in 2001. Then we had a post-pulmonary valve implant in 2010 with a Carpentier-Edward valve size 23 in 2010. Unfortunately, a Carpentier-Edward valves cannot be broken, so it cannot be enlarged further by a balloon technology. So there was severe RVOT obstruction. You can see that the procedure was done under GA with right femoral vein and right femoral artery access to assess for the coronaries and predilate. So that is the coronary angiogram which was done, and then the balloon dilatation. At this point of time, we did the coronary angiogram also and showed that there was no compression. So typically, this was a valve-in-valve procedure, and it was not a very difficult procedure. So you can see the Carpentier-Edward valves in position there. Unfortunately, we could not enlarge this bed further, and there was actually no need for doing a pre-stenting in this situation. And this valve was finally implanted, and finally you see that there is no obstruction and there is no pulmonary regurgitation. Finally, I'm just take a minute. Transcatheter pulmonary valve for native right ventricular outflow tract is difficult, but remember that these are the most common subset of patients which we encounter on a daily basis. Post-TOF repair with a patch. They have large right ventricular outflow tract which is dynamic in nature. They have a need for multiple pre-stenting in order to create a bed so that the valve can be implanted. The current study with the Melody valve showed only a 58% success rate. This was published in 2018 August, which means that these are very difficult subsets to finally succeed, and there is only a 58% success rate. The Edward Sapien valve may help further increase the implant success rate, but it has yet to be tried in these subset of patients. And of course, when the venous self-expanding results are still awaited, and it might further increase the pool of these patients who are subjected to these implants. Thank you very much.
Thank you, Dr. Radhakrishnan, for that excellent talk and excellent presentation. For all the pulmonary valve implantation, the Melody valve, we started for the conduit patient actually. Most of them were the conduit patient. It was nice to see a pre-implanted valve-in-valve kind of cases for the first time.
These are probably much more tedious technique. It is going to be much more expensive as compared to, especially when we start pre-stenting with covered stent. Each covered stent costs about 2 lakhs of rupees, and it requires multiple pre-stenting. It's a very difficult subset of patients.
So the conduits are sometimes heavily calcified, some gets dilated, and occasionally I used to find, when I was working outside of course, I used to find difficult to get the exact good case to do. All the conduit case we always pre-stent it.
Yeah,
and then implant the Melody valve.
That's the understanding now. Initially it was not, but now they actually have to pre-stent every conduit in order to prevent the fracture of the Melody valve.
All the valve, almost all the valve now, you need to check for the coronaries occlusion. And this is also to be taken seriously even for LA appendage closure, which I always keep on telling, so because the chance of circumflex getting closed is very high. Any question from the audience for Dr. Radhakrishnan?
Like in TAVR, if you suspect that you're going to possibly compress the coronary, if you have to do a TAVR nowadays, what people do is in a high-risk individual, they'll put a guiding catheter, they put a guideline and put a stent there. Has anybody done that? You show that the vessel during balloon dilatation of the pulmonary valve is getting compressed. Now you stent that area and then you do the balloon dilatation again and see. And if it is not getting compressed, maybe you not shift to surgery but opt for the.
Yeah, nobody has done that.
Actually,
They
no
just
one has tried that until now.
Probably
And
these-
probably if you do that, the stent is going to get compressed.
Probably these are very small, they are not very adult patients, you know, they are in their 20s and 30s. So nobody has done a stenting of the coronary arteries or pre-stenting in order to prevent, they just back out. It is an absolute contraindication as of today.
What is the balloon size where you test the coronary occlusion? Is it the same as which you use with the stent?
We have to keep on increasing the size of the balloon, at the same time do a RV angiogram and confirm that it is RV outflow is completely occluded, and then do the coronaries at that time. The flow has to completely go away from the right ventricle to the pulmonary artery.
Until you reach that, you escalate the balloon size.
Yes.
Thank you very much. If there is no further question, it was a nice session and a nice discussion. I think we all benefited. Thank you, Dr. Radhakrishnan, and all the speakers around over here. I also like to thank the panelists and all the speakers. Thank you very much.
Thanks, Amit, and thanks all the chairpersons, Manish, Dr. H.P. Singh, who's come all the way from Amritsar. Thank you. So we move towards the last session, but again, there is a lot of excitement remaining in the last session. So I'll call upon Dr. Vijay Trehan to take over as a chairperson, invite other chairpersons and the discussants for this session. And then last session revolves around the nightmares in cath lab, which is obviously very exciting. And it actually tests the temperament and abilities of an operator in the cath lab. So until the going is really going good, it's okay. But the real tests are waiting for you once going is unfavorable in the cath lab. So over to Dr. Vijay Trehan for the last session.